All right, this is just a short little bit on respiratory secretions. And one of the really fun things for me over the years has been teaching palliative care in different places. And when I was asked to do this, I thought, I know I've given a talk on respiratory secretions before. So I look in my stuff and I go through all my PowerPoints and can't find it. I finally found it in my file from Brazil. In 2008, I went to teach at a hospital in Brazil, which was a really cool experience. And there was my little respiratory secretions talk. That was interesting because it was teaching with simultaneous translation. And it was really odd because you'd be talking and I would tell a joke that I thought was pretty funny and there'd be nothing. And then about 5 seconds later, everybody would start laughing. It was really interesting. We've actually brought 3 residents from Brazil to do training in our unit. They've come for a month each, and that's been quite fun. So these are sounds. You all know what we're talking about. This is the death rattle, the crackly, noisy stuff that people get at the end of their life. And it's caused by movement of secretions in the hypopharynx or somewhere else in the respiratory system. I think you can divide this usefully into 2 groups. There's the stuff that happens in the last hours to days, and then there's the longer term stuff, weeks to months, which is, for example, ALS patients or MS patients, and that's a difficult problem. It's fairly common. So first we'll talk about the end of life stuff. Up to half the patients, and it's as death approaches, they become weaker, they're unable to swallow properly and clear the secretions, they're unable to cough and get rid of stuff, and the secretions accumulate. The main ones are saliva and bronchial secretions, but there's also other stuff. Infection, pus, tumor, blood, aspiration. So when we look at this, you need to be thinking, what is the context? What's happening with this patient? How close are they to the end of life? And who is it a problem for? Is it a problem for the patient? Not usually. Usually they're unconscious by this point, most of the time. Is it a problem for the family, the staff, or the roommates? It's nasty to listen to this, and I'm sympathetic. You go into the room and it's pretty uncomfortable to sit listening to somebody gurgling away. But you do need to be thoughtful, and does it really need to be treated in this particular case? Because we are giving them, it's an interesting ethical issue in that we're giving the patient drugs that are potentially uncomfortable, can give them a very dry mouth, and it's not a problem for the patient. So first of all, is it likely to respond? Is it upper airway secretions? If this is stuff down in the lungs, these drugs are not going to work. Okay? This helps the upper airway secretions, but it does not help blood in the lungs. It does not help pneumonia. It does not help pulmonary edema. It helps the upper airway secretions. Pulmonary edema is actually, it's very uncommon in cancer. We occasionally will see it in our heart failure patients that we look after in our unit. Between somewhere around 15% of our patients now are non-cancer, end-stage renal, heart disease, COPD. So part of this is educating the family. And I think even before you start the drugs, you need to be educating the family a bit about the fact that this isn't necessarily a problem for the patient. And we'll often show them, look, they're really quite deeply asleep, or they're even deeply unconscious. This isn't really bothering them. But it is difficult to sit here and listen to this, so let's give them some medication so it can be more pleasant when you're in the room. Make sure you're not overhydrating them. Positioning, our nurses are very good at trying to find just the right position where this stuff is the least bothersome. Occasionally suctioning, not very often, always very carefully and gently, and above all, do no harm. Sometimes just covering it up a bit, putting on a bit of music or keeping the TV going so that it's not quite so obvious. And you have to be aware of those things because our medications only work about 2/3 of the time on this. So we're trying to use anticholinergics to dry up these secretions, again, usually when the patient's unconscious. You want to start it early because once all the secretions are there, it doesn't make them go away. You're just preventing new secretions from developing. These are some of the drugs we use in the last day. We've traditionally used hyoscine hydrobromide in our unit. Victoria Hospice has always traditionally used atropine. I think hyoscine has slightly better side effect profile. You can use atropine eye drops sublingually. That's a good trick in the community. Occasionally that scopolamine patch, and glycopyrrolate is the drug that's, I think, on the community list. There aren't good studies, but it probably has less side effects. It doesn't cross the blood-brain barrier as much. It's probably a bit less sedating. So any of those things will work. It's really about, using one or two drugs and being familiar with them so you use them well. About 2/3 effective. And again, remember, who is this a problem for? Do no harm and start early. And again, educating the family. This isn't really a problem for the patient, but it's difficult for us to sit and listen to. Longer term, patients with ALS or MS, this can be a real issue. We had a fellow in a few months ago who was self-suctioning like 100 times a day. He would sit there with the suction in his hand. And, some ALS patients can't do that. He had primarily bulbar disease. It was cranial nerve stuff, and still had pretty good control of his arms. Very distressing. Usually we'll start with simple stuff, even amitriptyline, 10 or 20 milligrams a day. Sometimes we'll dry them up just enough. We're trying to use the side effects of these drugs to just dry people up enough that it helps. Sometimes it makes them worse because it makes the secretions thicker, and it sometimes is even more troubling. So you try it and see what happens. Probably the best treatment, and if you have an ALS patient who's heading down this road and is getting difficulty with secretions, think about Botox injections. They actually inject them right into the salivary glands, and it can be very, very effective in drying up those secretions. You can get pharmacare to pay for the Botox. If you've tried a few of the other drugs and you explain to them what it's for, they usually will cover it. And I usually get, there are one or two of the ultrasound docs, Kelly Matsuo and a couple of the other guys will do this. And it's better to do it with ultrasound guidance because then they're positive they're in the gland, and they'll sometimes put a tiny speck of dye in and they can actually be sure that they're going into the right place. I think experienced practitioners, Dr. Martin, the ENT guy, when he was here, he was quite happy to do this without any kind of guidance, any kind of imaging. But he was very, very skilled, but he's retired, and the younger guys are not too keen on doing it because they just don't have the experience. So usually I'll do this through radiology department. And phone and talk to one of the guys. Don't just send in a rec because it'll get sent back. No idea. That's one of the issues. Kim Waterman, the neurologist, has started doing a few of these, but Kelly Matsuo knows the doses, and yeah. Okay, any questions about the secretions or comments? All right, how are we doing time-wise? A little behind, but not bad. Okay. When do I need to be finished? We'll do our best. So the question's about a patient with esophageal cancer who's having trouble with the secretions, and she's not a candidate for a stent. So one of the most important questions, of course, is what's the context? What's the stage of her illness? What's her performance status? How long is she going to live? Because the treatments we choose are really dependent on that stuff. So how long is she got? Okay. So it's quite different if a person has a week to go or if they have 2 months to go, right? If the atropine, and if it's primarily saliva, then you just need to try harder with that group of drugs. Atropine eye drops, then I would try hyoscine subcutaneous. It's difficult because it's hard to find the balance between not making them so dry that they just can't stand it, and yet controlling the secretions. So titrating the doses and trying to find the right balance.